Okay, let's talk about obesity. What if our whole understanding of it is, well, more complex than we generally think? Today we're really diving deep into the latest science. Forget just, watching your weight. The evidence shows a much bigger picture. You sent us some fantastic sources, and our job, like always, is to pull out the really important bits, cut through the noise, and find those surprising facts about a topic affecting millions, maybe even you listening right now.
That's right. And our main source today, an overview of obesity-related complications, the epidemiological evidence, really highlights a major shift. The scientific community is moving away from seeing obesity as just a risk factor or a lifestyle issue. It's now viewed much more as a chronic disease, a multi-system disease. It's about understanding those deep links between weight, where fat is stored, and, well, bad health outcomes.
Okay, let's unpack that because, for ages, we've all heard BMI, right? Body mass index, that's the number. It feels a bit like learning the earth isn't flat. So, what's the main issue with only relying on BMI? Why isn't it the whole story?
That's such a key question. BMI is definitely useful for, say, looking at populations, screening large groups. Epidemiological studies use it a lot.
Yeah.
But for an individual person, it doesn't always give you the full picture of their health or their actual risk. That's why groups like the Lancet Commission and EAS, or the European Association for the Study of Obesity, are pushing for new ways to diagnose. BMI can sometimes get it wrong, frankly.
Get it wrong how? Like, someone seems fine by BMI but isn't? Or the other way around.
Exactly. It can underestimate or overestimate body fat for individuals. So the new thinking is less about how much fat overall and much more about where that fat is stored and, crucially, how it's functioning. Is it healthy fat tissue or not? So instead of just BMI, we're looking more at direct measures of body fat or things like waist circumference, even better waist-to-height ratio. These seem to be much better predictors of cardiometabolic risk, heart disease, diabetes risk, even if someone's BMI is in the normal or overweight range.
So you could have a normal BMI but still have risky fat distribution.
Precisely. Now, if someone has a very high BMI, say over 40, then yeah, it's usually safe to assume there's excess body fat without needing extra checks. But for many others, BMI isn't enough.
This brings up something I find fascinating, this idea of metabolically healthy obesity. If fat mass isn't everything, what about people living with obesity who seem okay, protected somehow?
Yeah, metabolically healthy obesity.
Yeah.
It's a really important concept because it shows the complexity. These are individuals who have excess body fat according to BMI or other measures, but they don't develop those early cardiometabolic problems like type 2 diabetes or heart disease as quickly. What we see in them often is lower fat in the liver and around the organs. That's visceral fat, but maybe more fat under the skin, particularly in the legs. They also tend to have better heart and lung fitness. Their fat tissue seems to function better. They have fewer markers of inflammation, and their insulin sensitivity is closer to normal.
So their fat isn't behaving as badly, so to speak.
In a way, yes. It highlights that the risk isn't just about having more fat. It's about how that fat is affecting the body's systems.
But is it permanently protective? Is there a catch?
Well, that's the caveat. While they might delay complications, some longer-term studies suggest their risk might still be higher over time compared to someone maintaining a healthy weight throughout life. So it's not necessarily a permanent get-out-of-jail-free card, but it definitely shows individual risk varies hugely.
Okay, this is where I think it gets really, really interesting. If it's not just the amount of fat, but how it's acting. Like you said, is it behaving badly? What's actually going on biologically? What connects obesity to so many different health issues?
Right. This is where the concept of adipose tissue dysfunction comes in. Think of this as the core mechanism. When you're consistently in a state of positive energy balance, taking in more calories than you burn over a long time, your fat cells, the adipocytes, they tend to mostly get bigger. That's called hypertrophy. They don't necessarily increase much in number.
They just swell up.
Kind of, yeah. And when they get too big, too stretched, they don't function properly. This leads to inflammation within the fat tissue itself. It changes the types of cells present. It limits how much healthy subcutaneous fat, the fat under the skin, can expand. And it encourages fat to deposit in places it shouldn't, like the liver or around the heart. That's ectopic fat.
Ectopic fat, fat in the wrong place.
Exactly. And dysfunctional fat tissue isn't just sitting there. Remember, fat is an active endocrine organ. It releases hormones and signals adipokines like leptin and adiponectin and inflammatory signals called cytokines. When the tissue is dysfunctional, these signals become harmful. They can promote diabetes, increase inflammation systemically, and contribute to plaque buildup in arteries.
So the fat tissue itself is sending out bad signals.
Correct. These signals travel through the bloodstream and directly affect other organs.
Hmm?
The brain, the liver, the heart, muscles, you name it. Take leptin, for example. Normally helps tell your brain you're full.
Yeah.
But in adipose dysfunction, the signaling gets messed up, which can affect appetite control. It disrupts that whole communication pathway.
Wow. It's like a communication breakdown caused by stressed out fat cells. So, thinking about these bad signals and misplaced fat, what are the biggest, most clinically relevant complications we see? How serious is this ripple effect?
Oh, the ripple effect is enormous. I mean, look at cardiovascular diseases. They're the top cause of premature death linked to obesity. Our sources suggest about 41% of deaths from heart disease can be attributed to high BMI.
41%. That's staggering.
It is. And that includes things like hypertension, high blood pressure, where obesity raises the risk by about 70%. Also, heart attacks, heart failure. Having a BMI over 35 triples your risk of heart failure. Strokes, atrial fibrillation too.
Okay, so cardiovascular is huge. What else?
You have the metabolic diseases.
What?
Type 2 diabetes is a classic example. The risk can jump more than tenfold as BMI increases. There's also dyslipidemia, abnormal blood fats, and MAFLD, metabolic dysfunction-associated fatty liver disease.
MAFLD is actually on track to become the leading reason for liver cirrhosis.
Liver cirrhosis from fatty liver? Yes. Driven significantly by obesity and adipose dysfunction. And the list goes on. Obstructive sleep apnea, osteoarthritis, the wear and tear on joints, mental health disorders, and several types of cancer.
Cancer too. Which ones?
The evidence links obesity strongly to cancers of the esophagus, colon, liver, kidney, uterus, and postmenopausal breast cancer, among others. The biological links to inflammation and hormonal changes are becoming clearer.
This paints a really complex picture.
Yeah.
So if the root is this dysfunction, can treating the obesity, losing weight, actually fix these complications? Can they be reversed? And I remember reading something interesting, that just removing fat, like with liposuction, doesn't actually help with the metabolic side of things. Why is that?
Yes, absolutely. That's the hopeful part. These complications can often be prevented, significantly improved, or sometimes even reversed with effective obesity treatment. Interventions that lead to weight loss lifestyle changes like diet and exercise, medications, bariatric surgery, they all work by addressing the underlying energy imbalance. And you're spot on about liposuction. It perfectly illustrates the point. Removing subcutaneous fat surgically doesn't provide those metabolic benefits. It doesn't improve insulin sensitivity or inflammation much.
Why not? You're removing fat.
Because it doesn't create the necessary negative energy balance throughout the body. It doesn't force the remaining fat cells, especially the deeper visceral fat, to shrink and restore healthier function. It doesn't fix the underlying signaling problem. It's about improving the whole system, not just sucking out some fat locally.
That makes so much sense. It has to be about restoring function. Okay, so when we talk about weight loss for health benefits, how much is actually meaningful? Is there a magic percentage or number?
It really depends on the goal, on the specific complication you're trying to address. There isn't one single magic number. For instance, if you're trying to prevent type 2 diabetes in someone with prediabetes, studies show even a modest weight loss, maybe 3% to 7% of their body weight, can make a huge difference.
Just 3 to 7%. That sounds achievable for many.
It can be, yes.
Oh,
But if someone already has type 2 diabetes and the goal is remission, getting blood sugar back to normal without medication, then you often need much greater weight loss. We're talking potentially over 10%, sometimes over 15 kilograms.
so the target depends on the problem.
Exactly. It's personalized. And this is where some of the newer treatments are really changing the game, especially the pharmacological options, the incretin-based therapies. You've probably heard names like semaglutide or tirzepatide.
Yes, they're getting a lot of attention.
And for good reason. In clinical trials, they're helping people achieve average weight loss of over 15%, even over 20% with tirzepatide. That's approaching the level seen with some types of bariatric surgery. Plus, they show really impressive improvements in blood sugar control, blood pressure, lipids, and there's growing evidence for direct cardiovascular benefits, possibly beyond just the weight loss itself.
That sounds almost revolutionary for treatment. But what about using them long term? Are they a lifelong thing? Are there downsides or challenges?
Those are definitely the big questions now. For many people, yes, these seem to be chronic treatments for chronic disease. Like managing high blood pressure, the benefits often rely on continuing the therapy. Side effects are possible, of course, like with any medication, mostly gastrointestinal, but they're generally manageable for most people. The biggest challenge, honestly, it's access and cost.
Making sure people who need them can actually get them.
Precisely. Ensuring these incredibly effective tools are accessible and affordable is a major public health equity issue we need to tackle. They work, but they need to reach the patients who stand to benefit. So pulling all this together, the dysfunction, the complications, the new treatments, what's the most important shift in thinking we need to make about obesity?
I think the absolute fundamental shift is recognizing obesity unequivocally as a complex, chronic, treatable disease. It is not a matter of willpower or a simple lifestyle failing. And because it's a disease, treatment needs to be patient-centered. The goal isn't just a number on the scale, it's improving health, improving quality of life, preventing or managing those complications, preventing that end organ damage. And we absolutely have to keep working to overcome the barriers that still exist. The stigma around obesity is still huge, even within healthcare. We need better training for providers, better systems to ensure people get timely access to evidence-based care. So when you, listening, next hear about obesity, try to remember it's so much more than weight. It's this complex disease involving how our fat tissue functions or malfunctions, affecting nearly every system in the body.
Exactly. And the future is really about understanding these details, these nuances, and using personalized science-backed treatments that target the root causes, not just the symptoms.
It makes you think, doesn't it? What stands out most to you about this evolution in understanding obesity? And maybe more importantly, how could this scientific view finally change how we as a society talk about and support people living with this disease?